So way back in 2016, you wrote a report that taught me a lot on vaping. And when I read that, I took two things. One, nicotine exposure in young people could be really harmful, and that's a very big area. But I also took a surprise, which was that the connection with these products and cancer is not there. And so this could be a major form of harm reduction for adults. Has your thinking on vaping changed in terms of a harm reduction strategy for adults?
Well, my belief back then in 2016, when we issued the first federal report on e-cigarettes in youth, was that there were very much as a possibility that e-cigarettes could be a useful cessation aid for adults if they were used entirely as a substitute for cigarettes and not as an addition to cigarettes. And while I still believe that, I also still believe that we continue to have a problem with youth access to e-cigarettes. Thankfully, we are in some ways in a better place than we were at the time I issued that report back in 2016. But we still know that there is no safe amount of e-cigarette use among kids, and we know that nicotine itself is highly addictive. So while I continue to believe that there's a possibility that it may help adult smokers in specific circumstances, I'm still worried about youth exposure to e-cigarettes.
Yeah, me too. And I also know that an area where you're passionate is in health information and misinformation. You've written and spoken a great deal on this. And I've heard colleagues that you and I both admire and respect say things like, don't let anybody tell you that these end devices, these electronic nicotine delivery systems, are any safer than traditional tobacco and cigarette products. And that makes my head spin because, as you say, there's no safe level. But I think by definition, they're safer. Would you agree?
Well, I think harm reduction is based on that notion, right? That there are degrees of risk associated with products and with practices, and here too, I do think that there is a degree of risk. I think one of the challenges that we were having with saying across the board that all e-cigarettes are definitively safer, especially in 2016, it had to do with the fact that we didn't even actually know what was in a lot of these e-cigarettes because they weren't at that time, well regulated, and the ingredients were often not fully disclosed. But by and large, because you're not combusting, tobacco and other products in the way you are with traditional cigarettes, one would believe that the risk of e-cigarettes, by and large, would be lower than what you would see with combustible cigarettes. Again, not zero risk. There's certainly risk associated with it. But if you had a patient who was able to completely substitute their use of combustible cigarettes with e-cigarettes, in certain circumstances that could be safer. And that's part of where we need actually additional study and evidence, because as thinking about this as a clinician, many clinicians have patients who are struggling with smoking. And in some cases, we do have FDA-approved products that people can use to aid with smoking cessation. In circumstances where people have tried those, though, and maybe they haven't had success, which is true for some portion of the population, the possibility there may be an additional cessation tool is potentially attractive. And that's why I actually continue to believe that that's something that we should be aggressively studying and then making available to people in safe circumstances.
Thank you so much. Let's talk about health misinformation briefly. How can the government do this? The example I always put in front of people is that if in February of 2020, someone had said on Twitter, now X, COVID is airborne, in a very rigorous kind of moment, if there had been a rigorous misinformation platform in place, that kind of messaging would have been suppressed. And in fact, it ends up being true, or at least very true enough. How do we do misinformation when science is always a moving target?
Well, gosh, one place where we have had to deal with this, Jeremy, has been in the field of nutrition, right? Like how much in our own lifetimes and careers we've seen nutritional science and information evolve and the recommendations change, and it leaves people exhausted sometimes. They're like, well, how do I really know what to eat anymore? We know that science evolves, and I think that's why when it comes to the communication that we do as clinicians in particular and as public health more broadly, we have to approach that with some humility, being clear with people about what we know now, what we don't know, and about what may change. And look, I know that that's hard to do, en masse, but that's something that clinicians actually have to do every day in the exam room, right? When we're with patients, a lot of times we have to tell them what we know, what we don't know. We may tell them, look, we're going to recommend this treatment to you today, but we're going to see how you do. We may have to change course. If you don't respond to this treatment, it may not end up being the right one for you. those are easier to have one-on-one, especially when you have a well of trust that you have built with a patient over time. And that's, I think, what a lot of this comes back to is, yes, in addition to approaching these topics with humility as we communicate about them publicly, one of the challenges we've encountered, Jeremy, is that there has been a real erosion of trust in public health and even in medicine, I would say, especially during the COVID pandemic, but even preceding the COVID pandemic. And there are a whole bunch of reasons for that. But I do think that any effort to ultimately better communicate about health needs to include a building of trust, a rebuilding of trust. And that starts locally. You don't put up a better ads, and that's not what gets you, more trust in institutions and in the profession. You rebuild that trust locally, not just doctors and nurses and their, with their patients, but that means what are we doing in our schools, in our communities, in our faith organizations, in our neighborhoods to bring clinicians together with the patients and communities they're serving so they can put a face to a name, so they can understand the people who are looking out for them. And in the middle of a crisis, then it becomes easier for them to take in the information, uncertain as it may be, and versus just hearing from a stranger with a piece of advice, which when then changes, they're led to believe, that person wasn't trustworthy, whereas that may not be the case.
Your predecessor, speaking of messaging, your predecessor, Dr. Jerome Adams, will sometimes post pictures of himself traveling, wearing a mask. And I'm wondering, with that message, how you comport with that messaging. I don't think I've seen you wear a mask in quite some time. And obviously, it's a different day as it was 4 years ago. But a lot of my readers are very COVID conscious, and they want me to ask you, do you mask ever? And if not, aren't you worried about the message that sends about regard for the most vulnerable?
Well, it's a good question, and you're right. A lot has changed and evolved in our masking practices. I'm Dr. Adams, who was my predecessor in this iteration. He was the 20th Surgeon General of the United States. He's a good friend of mine. We talk from time to time, and I also know I'm not revealing anything that's private because he has said this publicly, that one of the reasons that Dr. Adams masks in part because his wife. Is living with cancer and is undergoing treatment, and he wants to make sure that if he is because he is a family member who's immunocompromised potentially because of her treatment, that he's protecting her. And that absolutely makes sense. That's a very reasonable thing to do. In my case, yeah, there are circumstances where I do mask. Certainly when I'm in a clinical setting where masking is recommended, I will certainly do that. If I'm around people who are immunocompromised, I will certainly mask. If I'm in myself feeling like I may be getting sick, I will mask to protect people around me. So there are circumstances where I mask as well. And I know we're all navigating, this, in our own way to try to keep ourselves as well as the people around us safe. But I appreciate what Dr. Adams has done in not only setting an example, but explaining his rationale for masking and in recognizing that the exact practices that each person takes depends on their circumstances.